Good morning. My name is Dr.Andrew, and today we are going to discuss acute pancreatitis and the most important notes in acute pancreatitis that would be in the MRCS exam. I hope you enjoy studying with me. Okay. What is acute pancreatitis symptoms? Uh, the patient will came with tummy pain in the epigastric region. There will be also tachycardia, tachypnea, and shortness of breathing. The patient will had history of alcohol consumption or gallbladder disease, which both of them are the most common causes. But there is a lot of other causes like using of thiazide or autoimmune or some drugs that may cause acute pancreatitis. Okay, what is the differential diagnosis of acute pancreatitis? Uh, Maybe acute cholecystitis and ascending cholangitis, peptic ulcer, inferior MI. Okay, can you tell me why the patient will came with tachypnea and shortness of breath? Due to first abdominal pain. Second, there is a pressure of something called pseudocyst. Pseudocyst came from the inflammation of the pancreas, so it will form a pseudocyst due to infiltration after inflammation. There will be some sort of mucus secretion of fluid secretion around the pancreas, forming pseudocyst, which may cause compression manifestation. Okay, and finally, there is the acute pancreatitis may come with RDS, acute respiratory distress syndrome. Okay. Okay. Can you tell me how can I score the acute pancreatitis? There is a multiple scoring system. Let's start with Glasgow criteria. Glas- Glasgow criteria, there is a mnemonic called pancreas. Okay, let's write it vertically. Pancreas. P for PaO2 less than 8 kilopascal. Age, okay, let's write it with different color. Age will be more than 55. Here there is n. Okay. Neutrophils more than 1 15,000. C for calcium, less than 2 millimole. R for renal, and renal, the urea will be more than 16 millimole, which is renal function. E for enzymes, LDH, enzymes, LDH will be more than 600. A for albumin, which will be less than 32 gram per liter after 2 days. And finally is sugar for glucose. It will be more than 10 millimole per liter. Okay. Why there is increase in sugar? If the pancreas is inflamed, it can't secrete insulin efficiently, so there will be increase in blood sugar. Okay, what about the other criteria for scoring? There is a scoring called Ranson criteria. Okay, Ranson criteria divided into Ranson criteria on admission, which will be age more than 55, white blood cells will be more than 16. Remember, in Glasgow, more than neutrophils will be more than 15. Blood glucose will be more than 11 millimoles. Remember, in Glasgow, it was 10. And serum LDH will be more than 35, 350, and serum AST, which is one of the liver function tests, more than 250. Okay, there is other Ranson criteria, but after 48 hours. First, will be fall in the hematocrit more than 10%. Number two, there is a fluid sequestration more than 6 liter. There will be hypocalcemia less than 2 millimole. And 4, there is hypoxemia BO2 will be less than 60 millimeter mercury, and there will be increase in blood urea nitrogen, which will be more than 1.98 millimole per liter after IV fluid resuscitation. Okay, can you tell me what is the prognostic implications of Ranson criteria? Okay, If there is a score from 0 to 2, there will be 200% of mortality. And if the score become from 3 to 4, it become 15%. And when it become 5 to 6, it became 40%. And if the score from 7 to 8, the mortality rate will be 100. Okay, there is other scoring system called Baltazar CET score, which divided into grade A, B, C, D, E. In grade A, it is normal. Grade B, there is focal or diffuse enlargement of the pancreas. And grade C, there is hissness and sticky density in the peri-pancreatic fat. Grade D, there is single ill-defined fluid collection. And finally, grade E, which is the worst ever, there is two or multiple collection of the peri-pancreatic fat. This may take about 4 to 5 days to decide which grade. Okay, what the CT finding in acute pancreatitis? First, there will be edema, fat stranding, collection, which may be fluid, more fluid. There will be necrosis, abscess, and finally pseudo cyst. Okay, what is the pathophysiology of hypocalcemia? Why there is hypocalcemia with acute pancreatitis? Okay, because there is two stages of hypoglycemia. In the early stage, there is auto digestion of mesenteric fat by pancreatic enzymes as lipase. This will lead to increased fatty acids, which will form calcium salts. And these calcium salts will bind with fatty acid, so there will be a transient hypothyroidism and hypomagnesemia, hypoparathyroidism and hypomagnesemia. What is the late stage? As a complication of sepsis due to acute pancreatitis will lead to increase catecholamines, and catecholamines will lead to calcium shift into the cells, will lead to relative hypocalcemia. Okay. What is the management of the nutrition? The management first, there is TPN, total parental nutrition, will be needed in severe cases. And the trend nowadays is enteral feeding with enteral feeding with nasojejunal tube. Why nasojejunal tube? Because when the food pass into the duodenum, it will stimulate the pancreas to secrete its auto digestive enzymes, and it will be auto damage to a lot of organs. Okay, what is the complications of acute pancreatitis? There is hypovolemic shock, hypovolemic shock, hemorrhagic pancreatitis, which will present as a gray Turner sign, which will become in the flank area, and colon sign, which will become around the umbilicus. Uh, Acute respiratory distress syndrome, sepsis, and multiple organ failure. By the way, we forgot to mention that ERCP, which needed to excrete some large stone, may cause acute pancreatitis. So it may be due to gallstone, alcoholism, trauma, post ERCP, viral infection, hyperparathyroidism, and thiazide diuretics, and maybe idiopathic. Okay. We want to mention that amylase, which is one of pancreatic enzymes, uh, and there will be lipase. Both of them increase in acute pancreatitis, but amylase after 48 hours it returns to normal again. Okay, so uh, the level of amylase doesn't correlate with severity of acute pancreatitis. And can you tell me what is the factors that stimulate the pancreas to secrete its secretions? There may be vagal stimulation. Okay, vagus nerve can cause pancreas to secrete its secretions. And secretin, it is hormone produced by duodenum mucosa. Okay, and cholecystokinin. Cholecystokinin, it is released from the duodenum after fatty food. It also can cause gallbladder contraction. And finally, the gastrin that may be produced from the pancreas. Okay. What is the function of the pancreas? Pancreas can secrete a lot of secretions due to its cells. Its cells, it is divided into alpha, beta, delta, and the pancreatic polypeptide. Alpha secretes glucagon that will cause increase in sugar, in glucose, and beta insulin that cause decrease in sugar or glucose. There's somatostatin that will inhibit both hormones. This is the endocrine function of pancreas. There is also exocrine function, which are secreting of proteases. Proteases are trypsinogen, chymotrypsinogen, and proteases, and proelastases. And there is a lipolytic agent like lipase and phospholipase A2, and the starch digestion like amylase and the protease. Okay, we mentioned pseudocyst more than one time, and let's talk about pseudocyst. Pseudocyst is a collection of amylase rich fluid that is enclosed in a wall of fibrous granulation. Okay, there will be epigastric swelling, dyspepsia, vomiting, fever, and also there is compression manifestation. What are the complications of this pseudocyst? It may be ruptured. Okay, there may be infection, bleeding, can cause cholangitis, CBD obstruction, and portal vein thrombosis. Okay, can you tell me what is the management of the acute pancreatitis? As we mentioned before, TPN, or the trend nowadays, which is as we mentioned before, as we said, it is nasojejunal tube. Number two, pain management. We can give epidural analgesia. We can use as octreotides, antibiotics to prevent the complication of infection and sepsis. And we can use PPI to stop the stress ulcers that may be caused by acute pancreatitis. While the pseudocyst, there is a different management. If it is more than 6 weeks or more than 5 centimeters, I will use an internal drainage by cystogastроstomy or cystoduodenostomy. Why? I will make a tube between the cyst and the duodenum or jejunum to make this cyst to be drained into the duodenum and jejunum, so it will be disappeared. And I will take biopsy from the cyst wall to exclude malignancy, as it is more common with pancreatic malignancy. So I will take a biopsy from the wall of pseudocyst. Thank you for watching. I hope you get benefit from this studying. I hope everything will be fine. Don't forget to like the video and subscribe to the channel. Thanks for watching.